recommendations. I say, he was looking for my best interest. So why do we apply a different approach to healthcare? I'm just going to leave that question with you. Next, please. So, next section, applying evidence wisely, not being sucked in by big pharma and other agendas, or shopping with coupons for savings that are actually meaningful. There are coupons. So, which is better, 10% off or saving $100? Don't know, right? Next. So, in order to find your savings, you need two things. You need the regular price, you need the coupon value, and you need that'll give you the financial savings. In the realm of medicine, you need to know your baseline risk, the relative risk reduction of the therapy, that's a technical term, those multiplied together will give you the health savings in this case. So the health savings is something that is referred to as absolute risk reduction or risk difference.
Yes.
Next, please. So which is easier to sell? Now let's get back to this issue of language. Use vague language. Wunderpil reduces your risk of X. We hear those kinds of things. Relative risk reduction, the coupon percent value. Wunderpil reduces risk of X by 40%. Ooh. It sounds more juicy, scientific, and impressive. I would say that's a marketing approach. An evidence-based approach is to say the absolute risk reduction, the regular price times the coupon value. If your baseline risk is 10% over 10 years, Wunderpil reduces the risk of X by 40% of 10%, which equals 4%. This means that of 100 people who take Wunderpil 3,650 times over the next 10 years, and what is the math on that? That would be 365,000 pills. 4 will benefit and 96 will not. That is the state of affairs. When I learned this, I was like, pinch me, is this really? What's going on here? Again, get back to the 4 non-blondes. So we're now going to illustrate the concepts using the Mayo Clinic Statin Choice Decision Aid. Do you have that website? You can copy it from the, if you go back to that slide, you can just copy it into your browser. Maybe, I don't know if it'll let you copy and paste. So this is a tool that was developed by Dr. Victor Montori. Going to go back one.
Yeah, sorry.
That's okay.
Why did it happen here?
I don't know.
Uh-oh.
If you hit escape. Well, if you can get out of that screen, don't even go to the. Oh,
this one? Here it is.
There you go. Okay. So Dr. Montori developed this. He's been proactive in this. He wrote a book called Why We Revolt. That's on that list. He studied under Dr. Diet and is an endocrinologist at Mayo Clinic. So this site, I've used this in my practice, shows just this. Huh?
I'm going there. Just
okay.
keep going.
You calculate your baseline risk, and then you look at the intervention, and then you look at how much would benefit. And from that, you can see, it shows it in little smiley faces and frowny faces, how many wouldn't have benefited at all, regardless of what they did. And it'll help us illustrate something else. It's a very important point of this talk that I think reinforces the definitions of health.
Oh yeah, there's no internet in here. Did you not know that? Yeah, I told you that.
Oh, okay.
Yeah.
I didn't realize that. I have internet on the. Oh, I'm nuts. Well, I would encourage you, just go to this site. You'll see it. It will just show in graphic form what we just talked about. But here's the thing: when you go to the risk section. When you go to the risk section on here, there's one of 3 risk calculators. I just use the default one, the American Heart Association. And it plugs in a number of factors: your systolic blood pressure, age, gender, ethnicity, smoking, and so forth. And then that calculates a baseline risk. And what you can see, though, is that if you go back and toggle, say, oh, well, I'm going to quit smoking. You take that off there, and then you calculate your risk. You take off a couple of those risk factors, and actually you're doing more good than the drug interventions. Now that's not to say that in some cases you shouldn't do both. I just use it to illustrate, and it's an approximation. I mean, I can't say that it's going to reduce it exactly, but I think qualitatively or even semi-quantitatively, it will illustrate that in a very, very powerful way. But again, it's hard to do this with patients when you're rushed in your schedule and you've got slow EMRs and you've got click lags et cetera, et cetera, et cetera. And then people get mad because you're running behind and so forth. So next slide, please. So in conclusion, we've learned that correct language definitions and concepts are essential. Mnemonic, hey, what's going on? Health and healthcare, accountability and evidence-based. We've seen that to be evidence-based means that we have to really focus on this idea of outcomes. Statistically significant, clinically relevant, or important to me. Normal versus abnormal, who defines? And importantly, what difference does it make to me if I'm abnormal? Next. Ask what's going on. Know the true state of healthcare and how this impacts everything we've been talking about. And again, I would refer you to the resources for further study. And I will warn you, you're probably going to be pretty upset. This is really upsetting stuff. I mean, I'm kind of trying to rein it in as I'm up here. But that's why I feel like this is almost surreal when I walk through this information. But this is the truth. And if we're going to cure something, we can't call a brain tumor, a boil. So EMR and burnout articles will help illustrate this as well. Next, please. Build your skill. We learned that one of the tools in our Leatherman is that some evidence is inherently stronger than others. The two guitars analogy. Surrogate endpoints can be very important and they can be very misleading. Even good surrogates can be applied in a misleading or mendacious way, especially if you have a profit motive. Overdiagnosis happens when people are diagnosed with conditions that will never actually cause any meaningful bad outcome. That includes imaging, by the way. This isn't just lab values. How do you know that the more sophisticated our technology gets, the more difficult it is to distinguish what's normal and abnormal? Things that we didn't see before, now we see. Does this make any difference? We don't know. But now I've got a nodule on my lung. Or I have evidence of a stroke in my brain, or I've got cancer in my prostate, but a lot of people die with that, not from it. So to determine if treatment is likely to benefit us, we ought to know the absolute risk reduction, not simply the relative risk reduction. We need to know both the price, can I take this 65% off coupon, can I spend it on a new car? Well, hey, give me the coupon. Or can I only spend it at the dollar store? It's not worth my money. It's not a lie to say the coupon is 65% off for either one, but it really is misleading. And then the handout patient guide to evidence-based health choices to kind of help in anything that's being proposed, whether it be a screening test, whether it be any sort of what we call intervention. You can ask these same kinds of questions. And again, the benefits of being an EVP. One big reason that I continue in this, what some might say, like, didn't we learn this stuff in medical school? Why are you riding this horse? Because I find it liberating, and I see that patients are liberated by it. I see that it builds trust in the patient-physician or patient-provider relationship. And this whole idea with knowledge is power. And as you've seen, these are concepts that anybody can wrap their head around. If you can shop with coupons, we didn't go into it, but if you can diagnose why your ice cubes are melted in the freezer, you've got the principles of diagnostics and testing. If you can look at tire tread wear and know when you need to get new tires. So we use this in our lives, we just need to learn how to do it in medicine. And all these things, of course, by being evidence-based patients, we don't have to go for anybody's throat. By virtue of being that, we are going to bring accountability to healthcare because we're going to be pursuing true health, and we're going to be pursuing it in the model that is evidence-based practice or evidence-based medicine. Next, please.
That was the last screen.
That was the last slide. Okay, that's it.